Welcome to the deep dive. We're here to sift through that pile of source material and pull out the essential knowledge you need. No overload, just the core stuff.
Glad to be here.
Today, we're tackling a really critical topic: the complex reality of stroke, how it's managed, and what recovery truly looks like.
Yeah, it's a big one. You often hear the term beroerte used as an umbrella, but fundamentally we're looking at two main types.
Right, you've got the blockages, that's ischemic stroke, and then the bleeds, the hemorrhagic strokes.
Exactly. And our sources really guide us towards understanding what causes them, what happens in that crucial immediate aftermath, the acute phase.
And then the long haul, the recovery, especially those sort of hidden impacts on function and emotion.
And we really have to start with the stakes, because the difference between a blocked vessel and a burst one, it's profound.
Okay, hit us with the numbers. What are we looking at?
So based on 2019 data, if someone has an ischemic stroke, the blockage, the chance of dying within 30 days was about 11.4%, which is significant, obviously.
Yeah.
But for a hemorrhagic stroke, that spontaneous bleed inside the brain, the 30-day mortality jumps to 35.5%.
Wow, wait, 35.5%. That's nearly 3 times higher. What's driving that massive difference? Is it just more destructive damage or harder to treat?
It's largely the damage from the bleed itself, the sheer pressure and volume. You know, an ischemic stroke damages the area starved of blood.
Right, focal damage.
A hemorrhagic stroke does that, plus it physically squashes the surrounding healthy brain tissue because of the pressure buildup. It's, like you said, catastrophic mechanical failure, really.
Okay, that really sets the scene. So let's stick to that framework.
Yeah.
Cause, acute response, and then recovery.
Sounds good.
So starting with the landscape. Who gets strokes and why? We know age is a huge factor, but what do the general numbers tell us?
Well, looking at figures from 2020, for TIAs, the transient ischemic attacks, where symptoms resolve incidence in primary care, was around 3.1 per 1,000 people per year. For actual stroke or hemorrhage, it was about 2.0 per 1,000 per year in the general population.
Yeah.
And yeah, as you said, those numbers shoot up dramatically with age.
And we're still working with that rough 80-20 split. 80% ischemic, 20% hemorrhagic.
That's pretty much the breakdown, yes.
Yeah.
And crucially, the risk factors driving those two types are quite different.
Okay, let's focus on the 80% first, the ischemic blockages. What are the big risks here? Is it mostly about lifestyle and atherosclerosis?
To a large extent, yes. We're talking about the things you often hear about: high blood pressure, definitely smoking, high cholesterol, diabetes, drinking too much alcohol. These are the things that harden up the arteries.
The plumbing issue.
Exactly. But it's not just the pipes, it's the pump too. The heart plays a big role.
Ah, right. Like AFib.
Absolutely. Cardioembolic sources are a major factor.
Yeah.
Atrial fibrillation, AFib, is probably the biggest culprit. That irregular heartbeat lets clots form, which could then travel to the brain. Plus, you've got risks from heart valve problems or if someone's recently had a heart attack. Oh, and the sources also mention hormonal therapy, things like birth control or menopause treatments can slightly bump up the risk too.
Interesting. Okay, now let's flip to the other side. The hemorrhagic strokes. The brain bleeds. With that terrifying 35.5% mortality rate, what causes those?
Hypertension.
Yeah.
High blood pressure is, hands down, the main driver here. It damages those tiny, deep arteries in the brain.
Okay.
But it's not just high blood pressure. The sources also point to something called amyloid angiopathy, basically weakened vessel walls, which is involved in maybe 20 to 30% of cases.
And I guess blood thinners must be a factor here too.
A huge factor, yes. Obviously, any clotting disorders increase risk, but also the use of anticoagulants. That includes the newer ones, the DOACs, and the older ones like warfarin. They're essential for many conditions like AFib, but they absolutely carry this increased risk of bleeding.
It's a real balancing act then.
It is.
And what about differences between men and women? The sources mentioned something there.
Yeah, while the overall incidence is similar, women generally have their first stroke when they're older. See that reflected in the average age of death from stroke. It's about 83 for women, 79 for men.
Okay.
But perhaps more importantly, women sometimes present with less typical symptoms, maybe more generalized pain or confusion or just feeling off, rather than the classic one-sided weakness or speech problem.
And that could delay getting help.
Potentially, yes. If the presentation is unusual, it might take longer to get to the hospital, which could mean they miss the window for certain acute treatments like clot-busting drugs.
Right, that makes sense. Which brings us neatly to that acute phase, that time is brain mantra. How do we spot it quickly? The FAST test. Right?
Yes, at the FAST test: face, arms, speech, time. It's the standard screening tool, easy to use, even over the phone. Check for facial droop, arm weakness, speech changes. If any of those are positive, it's time to call emergency services immediately.
But, and this seems really important, a negative fast test doesn't automatically mean everything's okay.
Absolutely critical point. A negative fast test does not rule out a stroke, especially strokes happening in the back part of the brain, the posterior circulation.
What kind of symptoms might point to that instead?
Those often present differently. Think sudden, severe dizziness or vertigo that doesn't let up, maybe visual problems, double vision, or real issues with coordination or balance. Any sudden, severe neurological symptom needs urgent attention, fast, positive or not.
And when you say urgent, what's the time frame for getting medical help involved?
If the symptom started less than 12 hours ago, it's considered a top-level emergency. Code U1 requires an A1 ambulance response because, as we said, the treatments are incredibly time-sensitive.
Okay, let's nail down those treatment windows. This is where minutes really count.
So for ischemic strokes, the blockages, there are two main acute options. First is intravenous thrombolysis, the clot-busting drug like alteplase. Yeah. That's generally safe and effective, only up to 4.5 hours from when symptoms started.
Only 4.5 hours, that's tight.
It is incredibly tight. After that, the bleeding risks start to outweigh the benefits for most people.
And the second option, for bigger clots.
That's endovascular treatment, or thrombectomy. This is where they physically go in with a catheter and pull the clot out. It's for specific patients with a blockage in a large vessel, and the standard window for that is up to 6 hours.
Okay, 6 hours. But I read something about potentially extending that thrombectomy window way out, even up to 24 hours. How does that work?
Yeah, that's possible, but only for a very carefully selected group of patients.
Yeah.
Extending the window, sometimes out to 6 or even 24 hours, depends on advanced brain scans.
What are they looking for?
They're looking for a mismatch. They measure the size of the brain tissue that's already irreversibly damaged the infarct core and compare it to the amount of tissue that's struggling but potentially still salvageable, the penumbra. If there's still a decent amount of salvageable tissue compared to the dead core.
They might take the chance.
Exactly. It's about trying to rescue as much functional brain as possible, even later on. It's a calculated risk based on imaging.
Got it. So that's for strokes. What about TIAs? Those transient attacks where symptoms resolved. If someone sees their doctor quickly but can't get to a specialist right away.
There's a key recommendation there. If you see a TIA patient within a few hours and neurology isn't immediately available, the advice is to start them on 160 milligrams of aspirin straight away.
Kind of a blind start on secondary prevention?
Precisely. Get that antiplatelet effect going immediately while the full workup is pending. It's pragmatic. And just as a side note, the sources mention that things like the ABCD2 score, while known, aren't routinely recommended for primary care use because they haven't been fully validated in that setting. Stick to the basics: fast, urgency, and consider that immediate aspirin for TIAs.
Right. Okay, so moving past that initial crisis, we get into the long-term recovery. And this is where stroke really leaves its mark, isn't it? It's the biggest cause of adult disability.
It is, and recovery isn't simple. The biggest gains usually happen in the first few weeks, but improvement can definitely continue for up to a year, sometimes longer.
Is the outlook different depending on the type of stroke?
Significantly. After an ischemic stroke, maybe nearly half of survivors are functioning independently 6 months later. But after a hemorrhagic stroke, that figure drops to only about 1/3. The initial damage is often just more severe.
And we often think about the physical side effects first. What are the common ones that linger?
Motor problems like weakness or paralysis paresis still affect about half of patients 6 months out. Speech and language issues are also very common.
Aphasia?
Yeah, aphasia, which is trouble with understanding or producing language, and also dysarthria, which is the physical difficulty in speaking clearly. The slightly better news is about 40% of people with aphasia do recover fully within a year.
Okay.
We also see things like visual field loss, hemianopsia, and problems with swallowing, called dysphagia.
But the sources really hammered home the idea of the invisible struggle, the neuropsychological effects that might not show up right away but cause huge problems down the line.
Yes, this is incredibly important. These symptoms, fatigue, mood changes, cognitive issues, often creep up weeks or months later, and they can seriously derail rehabilitation and getting back to life.
Talk about fatigue first. It sounds like it's more than just feeling tired.
Oh, absolutely. Post-stroke fatigue is profound. Studies show it hitting anywhere from, say, 39% up to 72% of survivors. And it's persistent, often lasting more than a year. Crucially, it's not just because someone is depressed. It seems to be a direct neurological consequence.
You hear about people looking okay physically, but just being completely wiped out, unable to function because of fatigue.
It's a massive barrier. And then layered on top of that, you have depression. About a third of people who've had a stroke or brain hemorrhage develop depression.
And that affects recovery, too.
Definitely. The sources are clear that depression actually hinders physical and functional progress. Plus, we often see lasting cognitive problems, issues with memory, concentration, planning, that sort of thing, executive function.
And interestingly, this isn't just after major strokes. Even TIAs are linked.
Yes, that's a key point. Even after a TIA, where the physical symptoms were temporary, there's a documented link to ongoing neuropsychological issues like fatigue, anxiety, and depression. It reinforces that a TIA isn't minor, it's a significant brain event.
And if the patient is struggling with all this invisible stuff, fatigue, mood, thinking changes, the impact on their family, their partner must be immense.
Absolutely devastating, often. The sources highlight caregiver burden. There was one study showing 33% of partners developing depression themselves over 18 months.
Wow.
And often, the biggest stressors for caregivers are those neuropsychological changes in the patient. Maybe loss of initiative, being emotionally volatile, subtle personality shifts. It puts enormous strain on relationships.
So knowing that these long-term, often invisible issues are so central, what does good, effective rehab and secondary prevention look like?
It has to be multidisciplinary. The evidence strongly supports specialized stroke units during the hospital's day, followed by comprehensive care involving a whole team. Neurologists, physios, occupational therapists, speech therapists, social workers.
Right, the whole team approach. What's the specific role of, say, occupational therapy in tackling those longer-term issues?
Occupational therapists, or OTs, are really key here. They focus on getting people back to doing everyday things, activities of daily living, or ADLs, managing household tasks. But importantly, they also work directly on strategies for managing that fatigue and the cognitive difficulties we talked about.
Practical coping mechanisms.
Exactly. And speech therapists, or logopedists, work not just on communication, but also on safe swallowing for those with dysphagia.
Okay, and then there's preventing another one, secondary prevention. That recurrence risk is high if things aren't managed right.
Frighteningly high. Roughly a 15% risk per year of another vascular event if left untreated. So prevention is absolutely critical.
What does that involve? Lifestyle changes.
Big time. Strict advice, absolutely no smoking, regular physical activity. The goal is 150 minutes a week of moderate intensity. Trying to limit sitting time, ideally no more than 8 hours a day. Healthy diet, managing stress, all the things that protect blood vessels.
And medication. What's the standard approach after an ischemic stroke?
Patients need to stay on antiplatelet medication. Usually it's either aspirin combined with dipyridamole or clopidogrel on its own. If AFib was the cause, they'll need long-term anticoagulation, like a DOAC or warfarin. Plus, pretty much everyone gets a statin for cholesterol. And crucially, blood pressure control. Antihypertensives are vital. The guidance actually says treating high blood pressure is helpful even if the BP reading is technically in the normal range, lowering it as much as the patient can tolerate without side effects.
Aggressive BP management, then.
Yes. And finally, just a practical point the sources mentioned, driving.
Oh, yeah. When can people get back behind the wheel?
For a standard car or motorbike license Group 1, if there are no lingering physical or cognitive problems, people can typically drive again after just 2 weeks.
That quick.
Yeah, if fully recovered functionally. But if there are remaining issues, physical or cognitive, then the restriction is at least 3 months, and they need a formal assessment before being cleared.
Okay, that's a useful practical detail. So let's try and pull this all together. What's the core message from this deep dive? It feels like there are two kinds of urgency.
I think that's right. First, there's that immediate, intense urgency in the acute phase. It's literally a race against the clock to get treatments like thrombolysis or thrombectomy within those very narrow windows, 4.5 hours, 6 hours. Speed is everything there.
Right. Clock is ticking loudly.
But then there's a second, equally vital long-term urgency. That requires constant vigilance managing risk factors relentlessly to prevent another stroke. And just as importantly, recognizing and actively managing those often hidden consequences. The fatigue, the depression, the cognitive changes.
Because ignoring those is basically ignoring the biggest barriers to someone actually rebuilding their life.
Exactly. You can survive the stroke, but not truly recover functional quality of life if those aren't addressed.
Okay, so here's a final thought for you, the listener, to take away. The sources point out that stroke mortality has plummeted down by something like 65 to 69% between 1980 and 2019.
Which is incredible progress.
Absolutely. And that success is largely down to getting better systems in place. Specialized stroke units, much better secondary prevention medication and protocols. The system works when it's applied rigorously in the acute phase and for prevention. So the challenge now, maybe the provocative thought, isn't just about saving more lives initially. It's about taking that same systematic, comprehensive approach that works so well acutely and extending it fully to address the long-term, often silent cognitive and emotional fallout that prevents so many survivors from living a full life.
That really is the next frontier in stroke care.
Yeah.
Making recovery truly meaningful. And that, for today, is your deep dive.